This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Frontiers in Immunology, published in 2026, titled Neurosurgery as an Immune Anchor Point, a translational framework for perioperative immunoengineering.
This is a heavy hitter, Ilara. For years, we've been taught the classic narrative of CNS immune privilege, the idea that the blood-brain barrier acts as a hard wall, isolating the brain from the peripheral immune system. But this paper essentially argues that we need to stop thinking of ourselves as just plumbers or electricians fixing structural issues. It posits that the neurosurgeon is actually the primary modulator of a dynamic immune environment.
Exactly. The authors start by pointing out a clinical frustration we all share. Why do two patients with identical imaging, say a 30cc hypertensive ICH, have such different trajectories? One develops malignant edema and herniates, while the other stabilizes. The paper suggests this variability isn't just about structural damage, but is governed by the intensity, temporal rhythm, and resolution capacity of the immune response.
Right, and they use a phrase I love, neurosurgery as a programmable immune anchor point. They aren't just talking about the surgery itself, but the entire perioperative window. Ilara, let's dive into the structural foundations they mention. They highlight 3 or 4 key systems that have redefined our understanding of brain immune communication.
This is where the science has really moved fast. We aren't just looking at the BBB anymore. First, they talk about the meningeal immune niche. It's not just a sparse border zone, it's a rich, dynamic tissue. Second, they emphasize the meningeal lymphatic system, which provides a traceable route for antigen exchange between the CNS and peripheral lymph nodes.
And don't forget the glymphatic system. For the residents listening, remember that this is linked to CSF dynamics and astrocytic aquaporin 4 polarity. It's what clears inflammatory mediators and metabolic waste. If we disrupt this during surgery, or if we optimize it post-op through drainage and positioning, we are directly influencing the cleansing of the brain.
There's also a really interesting mention of a local supply pathway, myeloid cells moving directly from the skull bone marrow to the meninges. It suggests the very bone we're drilling through is an immune reservoir for the brain surface.
That's a paradigm shift. If the skull bone marrow is a local supply for myeloid cells, our craniotomy isn't just an access point, it's a biological intervention. Now, the paper breaks down the immune response into 3 temporal phases: acute, subacute, and chronic. Ilara, walk us through the acute phase.
In the acute phase, we're looking at sterile inflammation and barrier disruption. This triggers innate immune cascades. This is the peak control period. If the inflammation is too intense, you get that rapid edema we see in trauma or stroke.
And then we hit the subacute phase, which I think is where the most surgical influence happens. The paper calls this the period of immune resolution and clearance. This determines the quality of tissue repair. If the immune system fails to resolve the inflammation, you don't get healing, you get secondary injury.
And finally, the chronic phase. The authors link persistent immune-glia interactions and synaptic remodeling to long-term outcomes like epileptogenesis and cognitive decline. So an uncontrolled immune response weeks after a successful surgery could be why a patient starts having seizures 6 months later.
Let's pivot to the most challenging area of our field, glioblastoma. The paper asks a stinging question. Why have checkpoint inhibitors, vaccines, and cell therapies largely failed in GBM?
It's a tough reality. The paper argues that we haven't been leveraging surgical synergy. Most trials treat surgery as just a way to reduce bulk, but the authors propose using the surgical cavity as a local immunoengineering site.
I've found their concept of within-subject tripartite validation very compelling for research. Because we operate, we have access to 3 things simultaneously: the multi-regional tumor tissue, the CSF, and the peripheral blood. This allows us to see exactly how an immunotherapy is or isn't changing the local microenvironment compared to the systemic one.
And because surgery is a well-defined biological anchor point, we have the perfect before and after snapshot. We can deliver high-concentration therapies directly into the cavity, bypassing the BBB entirely, and then monitor the exudate or CSF to see the real-time immune dynamics.
That local delivery part is key. We're talking about using the surgical cavity for controlled release platforms. Instead of just a maximal safe resection, we're creating a bioreactor for the remaining infiltrative cells.
The authors also mention how our standard perioperative care, things we do every day without thinking, might be sabotaging these immune responses. Take steroids, for example. We use dexamethasone to control edema, but the paper reminds us that steroids can fundamentally alter the anti-tumor immune landscape we're trying to activate with immunotherapies.
Precisely. Even things like drainage, shunting, and patient positioning are framed here as ways to influence inflammatory clearance. We often think of an EVD just for ICP control, but it's also a portal to remove pro-inflammatory cytokines that the glymphatic system might be struggling to clear.
So what is the translational roadmap they propose? How do we move from these theories to the OR?
They propose a closed-loop model. It integrates structural pathways, like the meningio-lymphatics, with temporal dynamics. The roadmap involves spatial omic stratification. Instead of treating every GBM as the same, we map the immune landscape of that specific patient's tumor and anchor our therapy to the timing of the surgery.
It's moving towards precision perioperative management. The paper suggests that by integrating local immunoengineering, like putting engineered scaffolds or viral vectors directly into the resection bed, and then using spatial omics to monitor the response, we can finally break through the resistance of the CNS.
It really changes the narrative of a neurosurgeon. We aren't just removing a mass effect, we are managing a neuroimmune interface. For the residents listening, this means your post-op management, how you handle the steroids, how you manage the CSF drainage, even the timing of your follow-up imaging needs to be viewed through the lens of immune resolution.
It's about immunomonitoring. The authors are very clear that the uncontrollable heterogeneity we see in patients is actually monitorable, stratifiable, and intervenable if we use the tools they've outlined.
It's an exciting time. The immune-isolated brain is a myth. The CNS is a compartment where the immunity can be directly modulated by our hands. Whether it's hemorrhage, trauma, or tumors, the immune anchor point framework gives us a way to finally synchronize our surgical skills with the brain's own biological repair mechanisms.
It really is a paradigm shift. We've gone from avoiding the immune system to engineering it.
Well, that's all the time we have for today. To our listeners, keep an eye on the meningio-lymphatics and the glymphatic pathways. That's where the next decade of neurosurgical breakthroughs will likely happen.
Thank you for joining us. We'll link the full Frontiers in Immunology paper in the show notes.
Until next time, I'm Dr. Aris.
And I'm Dr. Alara. This is the Neurosurgery Hub podcast. Keep learning and keep operating.